And so I also wanted to thank the Medical Society for an opportunity to participate in the Leadership College this year. It has been a great year to learn about leadership. And so I am going to talk about our perinatal recovery groups at Blue Ridge Health. I work at Blue Ridge Health, which is a federally qualified health center in Western North Carolina. And I'm the medical director, a family doctor at our Polk County site. Polk County is a really beautiful little rural county nestled between Henderson County and the South Carolina border. And I want to start with a story.
I ended up getting pregnant again, and I was using through my whole pregnancy, and I didn't receive prenatal care. And he was born, and he's fine and everything, but a week after I had him, the DSS let me bring him home and everything, and then a week after I had him, I was really, really bad, and it got really messed up, and they took my kid.
The opioid epidemic has taken a toll in rural areas, especially on pregnant women. Doctors and healthcare providers in rural North Carolina are on the front lines trying to improve outcomes for mothers and babies.
We have certainly seen the effects of the opioid epidemic in rural Western North Carolina. And I think one of the populations that is starting to get a little bit more attention and that we are starting to more appropriately treat for opioid use disorder are pregnant and postpartum women.
In a way, pregnancy motivates women who struggle with addiction to get help.
The opportunity that we have when someone is pregnant or postpartum is unique in that they are highly motivated to take care of themselves, to have a healthy pregnancy, and to be the mom that they know they can be. That moment is a time that we could really capitalize on engaging women in treatment, developing a recovery plan, and helping them break the cycle of trauma, poverty, addiction, really changing the course of their life and their children's lives.
So I think it's important that we put a face and a story to substance use disorders and the crisis that we're seeing in rural counties all over North Carolina and nationally. April is one of my patients, and we'll learn a little bit more about how her story goes later in the presentation. But here are the numbers. They're pretty impressive. Substance use disorders are increasing from 2015 to 2017. The self-reported incidence of substance use disorders among pregnant women increased by almost a third, maxing out at about 16.6%. And among women who are of reproductive age, about 12% have a diagnosed substance use disorder. And some of the increases, when it's broken down, show that basically everything is increasing. So marijuana, opioids, we're seeing a big shift from prescription painkillers to heroin. As you know, we have more rules in place about prescribing prescription opioids. That's a good thing, but we're starting to see a little bit of an increase in heroin. And then recently, particularly since COVID-19 started, we're seeing a huge increase in stimulant use and methamphetamines throughout the state. I work in Polk County. This is a picture of downtown Tryon. And it's wonderful to work in a rural community for so many reasons, but rural communities have also been particularly hard hit by substance use and opioid use disorders. In rural counties, between 1999 and 2015, the incidence of opioid-related deaths increased about 325%. And also that's combined with a lack of treatment options. So in rural counties nationwide, almost 90% lack appropriate and sufficient opioid treatment programs. In Polk County specifically, there are a few things that make it an interesting place to treat substance use disorders, but also women who are pregnant or parenting. So in North Carolina, in Polk County specifically, about 60% of births are to women with Medicaid. That's pretty consistent with statistics throughout the state. So we have a high Medicaid population for our perinatal patients. but there are 0 delivery hospitals in the county. So women have to travel more than 30 minutes to deliver. And there's only, well, there used to be just one prenatal care provider, and you're looking at her in Polk County. But we recently hired a new physician at my office, and she's also providing prenatal care. So we have a second prenatal care provider. And then we've just seen this huge increase in pregnant women with opioid use, and the number of women presenting to labor and delivery with opioid use disorder quadrupled from about 1999 to 2014. So it's on the rise. And so in response to some of these things, at our site in Blue Ridge Health, in 2018, we started a comprehensive substance use disorder treatment program for an outpatient treatment program for women who are pregnant and then up to 1 year postpartum. We're really flexible with that because once people are doing well in the group, we hate to kind of have to shift them out. So we do have some folks with older kids as well that are just still benefiting from the group structure. And so the core of the perinatal recovery groups has been the group therapy process, but we also have medical care, including prenatal care, MAT. So for those who don't walk in this world, MAT stands for medication-assisted treatment. So that can be with things like buprenorphine, which you may have heard as Suboxone or Subutex. We also have individual therapy. We have individual psychiatric treatment if people need psychiatric treatment. This is integrated. RN, care management, and then care coordination with agencies like DSS, legal agencies, parole, probation, those kinds of things. So I wanted to take a look with my leadership project at some of the indicators of how we might be doing. And so we looked at kind of the number of participants referred, if they're staying in the program, how their attendance was, then if they were able to kind of maintain recovery by their self-report and also their urine drug screens, and then how their outcomes were in terms of their interactions with DSS. Do they have an open DSS case? Did their children require an extended stay or treatment for neonatal abstinence syndrome? And how many of them had drug screens that were as expected, meaning just showing the medications they are prescribed when they presented to labor and delivery? So I'm not going to show all of my outcomes. If you're interested, you can look at my write-up for those. I just don't have the time today. But what I did is I compared the outcomes of the perinatal program at Polk to one of our other Blue Ridge Health clinics that was providing non-perinatal focused substance use care. And what I found is that the outcomes were pretty good in terms of attendance. They were about the same as the non-perinatal focused services. But what we did find is that there was a big difference in whether or not their urine drug screen was as expected or as reported. And so we don't necessarily use urine drug screens in a penalizing way in the groups. We use them as information to help people judge, how they're doing with their recovery, kind of like you would use an A1C to help determine how well someone's diabetes is controlled. So it's just information. And it's often required for outside agencies like DSS, the Department of Social Services, Child Protective Services, or legal institutions that the patient may be involved with. So you can see that 74% of women had a urine drug screen that was as expected. And the attendance overall was pretty good. It was pretty on par with the regular services offered by the Rutherfordton Behavioral or the Blue Ridge Health clinics. The other outcomes that I felt like were really impressive were that of all the women that maintained in the program, they all had urine drug screens that were as expected when they presented for delivery at labor and delivery. So if they were taking Suboxone, that was the only thing that was in their urine drug screen. At the time of me gathering this data, none of them had an open and active DSS case. So no one had Child Protective Services involved in that moment. And about 40% of the babies born to these moms required an extended stay for treatment of neonatal abstinence syndrome. And that's about on par with what we would expect because many of the women are being treated with buprenorphine. And so you can see neonatal abstinence syndrome with buprenorphine. So that's not necessarily like that's an expected outcome of treating someone appropriately for their opioid use disorder during pregnancy. So the conclusions of what I found in my evaluation, we enrolled, or at one point or another, 12 participants came to at least one perinatal recovery group, and only 5 of them were retained over time. So we had a pretty low rate of retaining participants. And what we tend to see is that women who self-refer or present in pregnancy are more likely to stay engaged. Pregnancy really is this kind of magical moment of capturing people in this moment of motivation. And if you can get them engaged at that time, they're far more likely to stay engaged, even in the postpartum period. Women who are referred by DSS, they're more likely to be referred postpartum by the Department of Social Services or Child Protective Services after they, present with no prenatal care or with a urine drug screen that's abnormal to labor and delivery. Those women are less likely to stay engaged. The other thing that we saw is that women who actually lived in Polk County and were able to get to the services, the services were there where they lived, as opposed to being referred from an outside county, they were also more likely to stay engaged. So this is something we need to keep looking at, like what helps women stay engaged, because if they can keep coming to group, the outcomes are pretty good. And the other thing that we've seen is that we don't provide these services in a vacuum. We interact a lot with some of the other social services agencies and community partners that these women are working with, places like WIC, transportation, so Polk County Transportation, for those of them that don't have good transportation, social services, housing services, places where they can get, food and clothing and assistance for their kids. All of those things are as important, if sometimes not more important, than making sure that they have treatment for their substance use disorder. And then coronavirus threw a wrench in things, as everyone else is kind of a theme of this presentation. Right now we're doing everything virtually or in individual appointments. We are trying to start back up the perinatal recovery groups within the next couple of weeks. We're going to be doing outside visits with coats and social distancing and masks, because every single participant is begging to come back and get that kind of support and accountability that they get in the group. So moving forward, like I said, we're going to work on improving retention in the groups, continuing to work with our partner agencies, expanding the idea of these perinatal groups to some of our other sites, incorporating the resident learners that we have at our sites, making sure that the residents at the Mayheck Hendersonville Family Medicine Residency Group are getting training in how to appropriately work with women who are pregnant and postpartum and struggling with substance use. And then I'm hoping to further evaluate and use some of this data to look at, more extensively at how we're doing. This is my first kind of foray into data collection. I'm mostly a doer. I don't analyze enough, so this is good. And then we're going to finish with April's story.
April says the program has helped her. She's been able to stay clean throughout this pregnancy, her 7th.
I've been through a lot. My mom overdosed, and then I lost my son, and that was a lot for me to handle because I really didn't know how to handle that. So I did turn to drugs, and I was hanging out with the wrong people. I was just staying high all the time, and constantly seemed like I was constantly staying pregnant, and I just want my kids, to be a mom for my kids. And, not make the same mistakes that I did in the past, because I honestly don't want to end up like my mom. You know, she was 45 years old and overdosed, and, you know, it was an accident, I'm sure, you know, because she didn't mean to or whatever. But, you know, I don't want to end up like that.
So I'm really happy to tell you that the baby that was in her belly is a little girl named Harper, and she turned 1 yesterday. And her mom has been in recovery throughout the pregnancy and for Harper's first year postpartum. Not without struggles, but she's doing great. So that's the end of my presentation.
Thank you very much, Dr. Marietta. You have a couple of comments and a question. Comments, one from Sue Ann Forrest, who is our lobbyist for the Medical Society. She said, thanking you for communicating with your local legislators on a bill related to this topic. You also got a suggestion from Dr. Lacey Hobgood about possibly having your group meet in a large, well-ventilated room with appropriate filtration, et cetera, and maybe that could be a safe place if that's available to you. And then a question from Alicia DeTroy, who's a PA, and she wanted to know, have you considered adding an APP to expand your services? And a PA might really be a great member of the team to be able to provide both the prenatal care and the substance abuse counseling and treatment.
Yeah, it's a great idea.
I just want to point out to our audience that part of Leadership College training, if you haven't been through it, is training on how to present yourself when interviewed on video. So congrats to Dr. Marietta for looking stellar on her video. Was that before or after you had your training?
That was after, yeah. Or just right about the same time, like while I was in the Leadership College, so.
It was fresh in your mind, perhaps.
Yeah, exactly.
Well done interview. That was really, really nice to see. Well, thanks very much.